Dr. Seaton will be here by that time. Good morning, and a very, very warm welcome to the Health Evidence Review Commission's March 31st listening session. Thanks for being here and helping to improve healthcare for Oregon Health Plan members. Today, the meeting's being recorded. Next slide. We have Spanish interpretation for today, and that means everyone has to select a language channel, not just if you're doing Spanish language interpretation. So to do this, on your desktop computer, click the globe that says interpretation at the bottom. You might have to hit the 3 buttons that says more to find it. Or if you're on a phone or tablet, go ahead and click that more button with the 3 dots, and you'll find that.
I think Jessica will need to open the
Yeah, I
channel.
don't see it.
One moment. Victor or Rosie, would you like to interpret that, please?
Yes, I can do that. Thank you. Muy buenos días, bienvenidos a esta sesión de escucha de la Comisión de Revisión de Evidencia de Salud de HERC. El día de hoy tenemos interpretación simultánea de inglés al español. En unos momentos, interpretación va a estar disponible si se está uniendo a través de una computadora portátil o de escritorio. En la parte inferior de su computadora aparecerá un icono bajo el nombre de interpretación o interpretation. Es un icono como un mundo, selecciónelo, seleccione su lenguaje y no olvide silenciar el audio original. Si se une a través de una computadora, de una tableta, a un iPad o un teléfono inteligente, busque los 3 puntos bajo más o more, se desplegará un menú, seleccione interpretación y no olvide silenciar el audio original si le da la opción. Si necesita alguna ayuda para accesar interpretación, no duden en dejarnos saber vía chat. También hemos puesto las instrucciones. I also mentioned it that I have added the instructions in the chat. If they need any help, they can let us know via chat. Thank you.
Excellent.
I had to stop sharing momentarily to enable the globe.
Perfect.
Interpreting now enabled.
I'm going to switch into the English channel. Pick the Spanish channel if that's your language of choice. I can hear you.
And just as a reminder for all of those folks who want the English channel, you actually have to pick it. It's not a default.
Okay, next slide. Closed captions you'll see at the bottom of your screen. And you can select that if you'd like closed captions for this meeting. A new window will appear, and you can do that on your own. Next slide. We are going to be taking Q&A for the last topic today. If you look at the bottom of your screen, you'll see a Q&A button. It'll pop up and let you add text, but we do ask that you hold those questions for the last part of the presentation. Next slide. So today's agenda we're having right now, meeting purpose and introductions momentarily. We're going to have a general surgeon present about having surgery for fatty lumps called lipomas or fluid-filled sacs. Try to say that this early in the morning. Removed surgically. And then an occupational therapist will come and talk about treatments for ADHD and executive function for adults. Following that, staff will talk about a couple of things that may be changed in 2027. Next slide. Introductions. I'd like to introduce myself. You've heard me talking a bit. I'm Daphne Peck. I'm the Communications and Outreach Analyst for the Commission, and I arrange the listening sessions. Jason?
Hi, everyone. I'm Jason Gingrich. I'm the director of the Health Evidence Review Commission. I'm not a medical doctor or anything like that. I just supervise the staff here. I'm glad to have you all here today.
Ariel?
Good morning. I'm Ariel Smits. I'm the medical director for the Health Evidence Review Commission, and I'm a family doctor by training.
Excellent. Liz, did you get to be made a co-host?
Yes. Morning, everyone. My,
Excellent.
my name is Liz Walker. I'm the policy analyst for HERC. Have been on the team for about 5 years now.
Great. And Jessica.
Yes, I'm Jessica Malmstrom. I'm the administrative support person, so I'm going to be advancing slides today. And yeah, I do the logistical stuff for the HERC team.
Excellent. Thank you so much. Next slide. Our goals for today for staff is to listen and learn. We'll be asking questions and taking good notes to bring back to the commission. If any concerns pop up that we can't address, we will connect people with the right resource. Next slide. So just what the heck is HERC? Well, that's a good question. HERC is Health Evidence Review Commission, or HERC for short, is a governor-appointed panel, and it's confirmed by the Senate, and they're responsible for making healthcare coverage decisions for the Oregon Health Plan, considering public input as well as evidence reviews. The commission ensures that certain medical procedures, devices, and tests paid for with Medicaid dollars are safe and proven to work. Today's listening session isn't a public meeting per se. It's not a commission meeting. It's not a subcommittee meeting. No policy decisions are being made today. Our purpose is to provide a space to listen to concerns and suggested topics, and for staff to answer questions related to the commission's work, which is that evidence review I was talking about and setting coverage policy for the Oregon Health Plan. In the 2 years since we've been holding these sessions, these discussions have helped improve care policy for OHP members. I want to just point out, though, that the commission doesn't have authority over rates, licensing, or quality standards. Next slide. A wonderful resource I'd like to point out to everyone, and I'm going to drop this in the chat. The Ombuds program with the Oregon Health Authority, or OHA, helps members, OHP members, with denials, filing grievances, and a whole lot more. So they're a wonderful resource, and that's the website where you can get in touch with them if you need it. Next slide. In engaging with us, you can sign up to receive notices about our work, including listening sessions. There's ways you can offer comment and attend meetings and emailing us. I'm going to pop those links in the chat. There they go. Next slide. And our next session for our listening sessions is, sorry, I'm getting links for you, is April 30th from 6 to 7:30 p.m. And we're starting to collect topics for vetting, and that'll be great. So at this time, I'd like to turn the meeting over to Dr. Schmitz, and hopefully our first person is here.
Welcome, everybody. Thank you for taking time out of your day to attend. These sessions are a chance for HERC staff to hear your concerns, whether you're a provider, a patient, a family member, and previous listening sessions, people have brought up important issues that have actually gone to the commission and changed how OHP delivers care. So this is really important to us, and we're really glad that you have been able to join us for this.
I do see that Dr. Seaton has arrived. Dr. Seaton, I'm trying to make you a panelist, so you have to accept it.
I see somebody has a hand raised. Did we?
Okay. Yeah, let's see what's up. Hi, Carolyn. How can I help you?
Hi. So the chat's been disabled, so I can't see any of the links. And I don't know if that's the same for anybody else.
Oh,
I'm
you
not
know,
seeing any links either.
I sent
Yeah.
them all to interpreter. Just having a wonderful time today. Rosie, you've got double and triple things from me. There you go. Can you see them in chat now?
Yes, thank you.
Thank you for letting me know. I really appreciate that. And apologies for the sorry for not making that clear.
Not a problem.
Yeah, and I would just recommend that you all look at those pages and things. We do have lots of other ways that you can reach the commission or staff. Those are just a variety of the ways. So if anything comes up today or you're not able to speak today, but you still had concerns, we're happy to be in touch with you by any of those means.
Absolutely. Dr. Seaton, I'm going to press the button to allow you to talk. So, oops.
Is it working?
It is.
We can
Thank
hear
you so
you.
much.
Okay, great.
Dr. Seaton, we can't see you. I don't know if you were trying to be on
I need-
video. If
I
you
need
just
to-
want to be on audio, that's fine as well.
I need to change her settings for camera. Jillian Seaton. Well, now I've lost you.
I see her. She's still.
I see her too. I just don't see. Oh, there she is. Okay, I'm going to promote you to a panelist. And once you're promoted to panelist, I'll let you share your camera. Sorry for the. Oh, Jessica, can you promote Dr. Seaton to panelist?
She's showing up there now.
Sorry, to a co-host so she can show her camera.
Oh.
I said the wrong thing.
Just promoted her now.
Great. All right.
Welcome, Dr. Seaton. Glad to have you.
Thank you for having me on.
Hey, Dr. Seaton, it's great to see you face to face.
So what can I talk about?
So I'm Ariel Smith. I don't know if you were here for introductions. I'm the medical director. With us is the whole staff, Jason Gingrich, Liz Walker, Daphne Peck, and Jessica Maelstrom. We're all the HERC staff. So we're happy to hear anything that you want to tell us. If you're having any things denied, if you want to kind of argue for improved coverage. It looks like you had kind of had concerns about lipoma and cyst removal. But you know, the floor is yours for 10 minutes, so whatever you prefer to talk about.
But well, it was actually the two things. Daphne was very helpful because I've had all my elective hernias denied for
Okay.
in the 2.5 years I've been here. Got one patient with extenuating circumstances be approved, but I just had 2 cysts and lipoma removals denied. And we're talking small lesions, generally under 5 centimeters. Typically ones I could do in clinic, although for my back, sometimes I want to do it in the OR, still awake, still a minor procedure. But typically if over 3 centimeters, we recommend those be removed because cosmetically it gets much more difficult to remove later. Once over 10 centimeters, it's 100% recommended removal rate because the cancer risk goes up. So typically we take them out before they get that way because it's a lot easier to do so. I find it a little bit ridiculous that they keep getting denied because it's not an urgent, it's not an important thing. And I don't know what we're doing wrong to not get those approved, especially because these are things that are much more minor now rather than say waiting until they're 8 centimeters in size and much more difficult to remove. So this is the advocacy where I'm saying, can't we discuss about covering some of these minor things? These are not cosmetic. I'm not taking them out because they're cosmetic. I'm taking them out because they've been growing. Let's take them out before they get giant. I can see denying them if they're really small and not growing, but they're still denying these growing 5 centimeter dermal, so not dermatological problems. These are subdermis, subcutaneous lesions, and that's the concern.
Okay, so anything before I jump in, anything else that I'm happy to let you ask you some questions and
Yeah, that was just the one. It's just frustrating for patients. It's frustrating for me because the guidelines are to remove these.
Yeah.
So why do we keep getting denied? I mean, it's possible we're not missing documentation, but I'm putting in there that they're growing. I'm putting in the exact dimensions. I'm putting in what it's going to take to remove them. Some might require some advancement flaps or a little bit more complicated closure, but we're still not talking anesthetic. We're still not anesthesia. We're not talking the patient needs to be in a complex scenario to do these because those usually get approved. That's the irony.
Okay, so I'm going to start from the beginning. You had said that you're getting elective hernia repairs denied. We expanded our hernias. You have to document that they're causing some
They have to be symptomatic, painful.
Yeah, exactly. I
Frustration.
had our guideline just up. Let me pull it back up again. Did Daphne share our current guideline with you?
Yes. Yeah, and these are symptomatic hernias. I don't typically recommend repairing hernias that aren't symptomatic. So these are painful hernias, typically not with a history of incarceration. So these are elective repairs and towards avoiding an emergency repair when it is incarcerated. Because what we're getting in the denial is that they don't do elective repairs. It's only if it's an emergency situation do they do hernia repairs.
So I don't know which CCO you're dealing with, but that's not correct. That's our older policy.
Okay.
So our current policy, we can share with you offline. I can pop it into the chat, whatever's easiest for you. Obviously, if there's symptoms like intestinal obstruction, those have always been covered. But now pain and functional limitations, as long as you document that in your note, in
Job. Can't hold down a physical labor job.
Yeah,
So,
or affects ability to obtain or maintain gainful employment. So
right.
Those are our criteria. So if you can document any of that, if it's still being denied, Jason, because that's not the HERC intent or our current guideline. So what would be the best approach there, Jason?
Yeah, and you can always the patient can always file an appeal, and they have hearing rights. So there are administrative processes to appeal those.
You
and
can
have
also
them reconsidered, and you could refer to that guideline note that I believe Daphne provided you in support, and make sure your documentation supports that.
Yeah, and you can always call the CCO and ask to talk to a medical director. And then you can say, my patient cannot work or whatever the situation is due to this. Your guideline note 24 clearly says that's covered. What additional information do you need or however you want to put it? And hopefully that if you continue to get denials, definitely let us know or someone else at OHA because that's not appropriate. As long as Jason mentioned, if you need to document in your charting somewhere that this patient is unable to work or unable to do, is in pain, has trouble walking because of pain or whatever your concern is.
Keeps coming into the ER.
Oh my gosh.
I would think that technically, I don't know if it meets our criteria, but that would be causing pain. Plus, most of the time, CCOs are happy to cover a surgery to keep somebody out of an ER where they're paying over and over for the ER fees. So
I think it's only 2 ER visits and you would cover the cost of the surgery.
Right.
Yeah. Yeah. And we liberalized our hernia guidelines within the past 12 to 18 months. So it is a little bit newer. So just in making sure that whatever CCO you're working with has up-to-date guidelines.
Well, probably what we'll do is we'll just try to go back and find everybody and resubmit so that, and then reference the guidelines and say, yes, you do cover these now. So can we please get that fixed?
Yeah. And yeah, this has been a hot topic for years. So I'm surprised that but again, it could be just something in whatever the processing PA, the reviewer level PA haven't been, they don't have their criteria updated or something. But hopefully that shouldn't be a problem going forward.
Our authorization team didn't know that either.
Okay, and did Daphne send you our current guideline, or do you need that sent to you? Okay. Yeah, so inguinal is part of our hernia, Jason. It's inguinal and femoral.
No, but the question Dr. Seaton is asking about inguinal hernias, not ventral or umbilical, correct?
Well, I was talking about all hernias.
Okay, so the policy Ariel is referring to is about inguinal hernias
And femoral.
and femoral.
And so you still don't cover umbilical hernias, symptomatic umbilical hernias.
No, that is our continued policy. Yeah. And if you want to come and talk to anyone and the commission, you're welcome to either submit written or verbal testimony. We only cover them if they are actually not even incarcerated because, yeah, they would have to be like strangulated or some other, gangrenous or something.
Pretty sure you cover incarcerated because the degree of whether it's like strangulated versus non is hard to differentiate prior to surgery. So, but umbilical hernias typically do get incarcerated as it's scarred, so they don't reducible. So I usually don't call them incarcerated unless they've actually got an acute episode. But yes, I would advocate for that to be covered too, because that's a significant problem for people. So if that's still not being covered, I'd be happy to come and give testimonials. And also because it also affects working performance.
Okay. So it sounds like umbilical and femoral you should have covered, but are you talking just about umbilical or all sort of ventral hernias?
I'm talking about all hernias.
We looked at ventral not too long ago, didn't we, Erin?
Yeah.
Because ventral are typically what they mean when they talk about ventral hernias are much more debilitating even than inguinal.
Yeah, if I recall, the conversation was that the need for a repeat surgery within 5 years is like 30 to 80%, depending on the type of ventral hernia. I think that's where the concern lay. So if you know anything about that,
I think that number is way better now. I mean, it matters on the type of hernia and the extent of the hernia and all that kind of thing.
And the patient, other factors of the patient,
but
yeah.
30 to 80% seems really high.
Okay. What I would suggest probably is you're welcome to submit written testimony, or at each of our meetings, we have time set aside for things that aren't on the agenda. And Daphne or Jessica can send you how to kind of sign up for that. And if you want to take a little bit of time and just talk to the commission about your concerns and, what you're seeing and answer questions.
Dr. Seaton, I just put that link in the chat of how to engage with HERC, including how to submit topics. So if you click that, there is an instruction. And if that's not clear, please call me and I'll help.
Yeah, and you can either submit that as a topic, you can sign up for giving public testimony. So our agendas are kind of set for the next few meetings, but we always have this time for topics not on the agenda.
Mm-hmm.
And we're happy to hear any concerns you have. And it's usually the end of the meeting, so sort of lunchtime-ish that we usually hear that kind of thing, if that would work in your schedule. And like I said, we are happy to hear that. Normally, when you bring up something like this, I would make it a topic, but we just talked about this in the last year or so, and the commission usually doesn't choose to talk about topics again unless they're kind of convinced to, and if it hasn't been 5 years since if it's been less than 5 years since the last time we discussed it. So That's where I'd suggest you start. And then the HERC.info, just email that if you need any kind of help navigating, and we can kind of help. And then your other topic is actually really timely, the lipoma and cyst removals. We currently don't cover them. They're on an agenda, and this is probably not going to be helpful for you, but next week, Thursday. So very probably, I don't know if you would have time, we can send you all the meeting information for that, but generally a week and a half from now might not work in your schedule. But if you wanted, you can see all of our meeting materials should be published this Thursday. The staff recommendation is to add some coverage. I wasn't aware that there were guidelines about size, and if I could ask that from you, if you could send me any guidelines that you have, specialty guidelines, articles, anything that would relate to sort of what standard of care and when to remove things. That would be really helpful. So we
I
are
think the
doing,
guidelines just say growing, but most
Okay.
patients don't notice growing until it's at least the size of a 3 centimeter or larger type of lipoma. I mean, to me, it's a little harder to say whether it's truly growing, but once it gets
Right.
to be big, it's much more obvious to see that it's growing. And so I think that's why that's usually where we start to say, yes, it's a real thing. If you've got a lipoma that's bigger than 3 centimeters and growing, then it becomes a significant concern. But yeah, I don't
Yeah,
see what I find.
yeah, and I
It's
had
usually in
said,
textbooks. I don't know if that's usually the stuff
oh no,
that's
textbooks is great.
stuff, but I
Anything,
know I've seen some other articles, so I'll go back and find those.
yeah, and then I think the commission in the past has felt these to be mostly sort of annoyance or cosmetic. If you have any information on like, I think what I had just proposed was pain and functional limitation, kind of like our hernias. Um, but any information you have on that would be really helpful. Um,
I can't. I mean, most of that's going to be anecdotal.
but
Patients always say
even
it
if
hurts,
you want to write a written statement,
yeah. I mean, they say it hurts, but I don't really necessarily buy that. I usually encourage them to consider it more in terms of, is it in a place where, like on your forearm, are you constantly hitting it on things?
or like on your back where your
Your
shoulder
jaw
blade is
or your
moving, or
waistline or something like that. Or it's an area that's not particularly, like I had one this week on the shoulder. And it's not a particularly fatty area anyway, so can be very prominent. And if you wait until it's giant, you actually end up losing a lot of the fat pad, and you get a really funny cosmetic effect after the fact. So it's much better to take it out when it's quite small, before it distorts some of the normal subcutaneous tissue there. At least that's what's been in my experience. But again, it comes back to that growing definition. Once it's growing, then they recommend removing it, even though they're almost always benign, unless you get to more than 10 centimeters in size. So
that would be really large. Okay, so what I would propose for next steps for you would be we will be publishing our final meeting materials this Thursday. Daphne, do you mind dropping the link to where we put meeting materials? This is for EBGS. So this is one of our
Absolutely.
subcommittees. And they're going to be talking about this next week, Thursday. The materials will come out this Thursday, and you are invited to put in any written testimony, so you can look through the meeting materials. And then you can put in any comments that you have, like, this kind of what you're telling me right now, but you could, put this in writing, and
Right.
then we will bring that up at the meeting. This is a subcommittee that is meeting next week. If you're available, you are more than welcome. There are public meetings. It is 2 to 5. Is it 2 to
Yeah,
5?
that's correct.
Next Thursday, and a virtual or in person if you wanted to come to Wilsonville. But you are more than welcome to attend virtually, and you you can sign up to give public testimony. I'm not sure what time in the meeting because we have multiple topics, but if you are available Thursday afternoon, that is definitely an option. Depending on whether the subcommittee gets done with their review and approves something, this is planned to be brought up at our May 15 meeting. which is also virtual and in Wilsonville, in the afternoon, and that is actually with the HERC itself, and you are again more than welcome to sign up to give public testimony. Meeting materials for that meeting will be published a week before, so May 8th, if you want to see kind of what the decisions were at the meeting next week to see if there's anything. And I will bring up what you have told us today, regardless of, if you submit anything in writing or come to the meeting.
But it'd be helpful if I gave you that stuff before Thursday.
I think it would be really helpful. You can send something to me before Thursday and we can put it in as public comment. You can submit it after Thursday on the official public comment page, whatever works best for you. And we will make sure we bring that up when we discuss things. And then staff will keep in touch with you. So these are a series of changes that we're looking at all of our non-covered services and seeing what we need to change. So there's a whole bunch of different types of topics. So if they kind of get to this point and they're like, we don't know what to do, or can you ask Dr. Seaton something else, or inviting you to come and speak or whatever they want to do, staff will be in touch with you. And even if they're like, sure, sounds great, we'll approve it, we'll just get in touch with you and let you know that was the decision.
Okay, sounds great.
Yeah, thank you for bringing that up. Like I said, it's very relevant.
Well, it's amazing that you guys are reviewing this because I thought that was kind of a hopeless thing. We just had to accept that it was never going to get covered.
No. I cannot guarantee anything. We are staff. We make recommendations, but we don't make decisions. So
even so, this is still really good because a lot of times we and patients don't feel like their needs are being met or heard. So the simple fact that there's an avenue for the plea to be made is really great.
And just for your information and for all your patients, if there's even more topics or other things that you run across where you're kind of saying this doesn't seem right, we are always open. The HERC.info is probably the best way to contact us. There might be a really good reason. There's strange federal rules. Sometimes it's a budget thing where we want to cover it, but the legislature won't let us. And other times it's just something we haven't thought about, and we're really happy to get your input.
Okay.
Or your patients, if they really feel strongly that something should be covered or have concerns, they can reach out as well.
Okay, great.
And all of our meetings are public, and there's always a time for public testimony, even if it's not like next week, the dermatology, well, I guess we're lumping it under dermatology, even though I agree with you, it's subdermal.
Yeah, and dermatology doesn't touch this stuff.
I get that. We had to kind of lump things under general categories in order to get through this. So I acknowledge it's the wrong category. It's more of a general surgery thing, but
yeah.
So that will go forward. But if something else comes up and you're finding some problems, we are always happy to hear.
Great. That's perfect. I really appreciate that. Thank you.
Absolutely.
Yeah. Jason, any other thoughts for Dr. Seaton?
No, just thank you for taking the time to raise these concerns, and we'll make sure they get a careful look.
Thank you.
Yeah, and if you are available next Thursday, please come.
Yeah, I'll see what I can do.
No feeling pressured.
It's likely it won't be the first half hour or so of the meeting, and we can be somewhat flexible after that if there's a specific window that's best. So let us know.
When does the meeting start?
It's 2 to 5.
Yeah. 2 to 5. That's right.
But yeah, but if your day is busy until 4 o'clock or something, we can hold a little time for you if you know that you want to come.
Usually it's totally hit and miss, so
understand.
I give you a forewarning necessarily.
Okay. Yeah, and same with the HERC meetings. We do have this time reserved for public comment, but if we know you're coming and want to give a comment, we can try to work with you on a time.
Okay.
Okay, well, we have run right through our break, so should we push on?
Yeah. Anything else, Dr. Seaton?
Mm-hmm.
Okay. So I have no doubt we'll be in touch. So thank you.
Thank you.
Thanks so much. Do folks need a 5-minute break?
I'm fine.
I'm good.
Okay. Well, let's move on to the next section. Get that up. We've got Betsy Gaffney here today, and I noticed she was in, there she is. Betsy, I'm going to make you a panelist, and then we'll promote you to a co-host so you can share screen. And I'm sending the invite right now. Jessica, can you make her a co-host as soon as she shows up?
One moment.
There she is.
Can y'all hear me?
Yes. Hi, Betsy.
sweet.
Thank you for coming.
Yeah. Oh, there I am. Okay. I was trying to figure out how to make the video work. But yeah, here we are.
Yeah, thanks so much.
So should I share my screen or are the slides available for someone else to control? I wasn't sure.
We're ready to share your slides.
Okay. So would you like for me to share them on my screen?
Oh, no, we're ready to do it. So, Jessica,
it.
can you pull
Okay.
those up?
Okay.
One moment.
All right.
Appreciate you for being here today.
Yeah, I'm excited. It's a very different topic, so it's a lot of information that I'm going to share, but yeah, feel free to stop me at any point if you have questions or want to talk about it more.
There we are. Can you see my slide?
Seems like it's coming up.
There
There
it
we
is.
go. All right. Let me know when you want me to get started.
Right ahead.
Okay. So I'm Betsy. I'm an occupational therapist. I work in an integrated health facility. We serve almost exclusively OHP. I got interested in this topic because now I'm working with adults, whereas previously I was working in pediatrics. And I worked a lot with ADHD in that setting. And now I see how those treatments can actually translate into adulthood as well, because a lot of my adults are having similar issues. So you can go ahead to the next slide. All right. Just to make sure everyone is on the same page, that everything is clarified, I have added the diagnostic criteria based on the DSM-5, DSM-5-TR, actually the most recent. We've got 3 different categories. We've got the hyperactive impulsive, which I think most people are familiar with. This is excessive motor output. These are people who can't sit still, kind of blurt out things, or impulsive, sometimes to the point of being unsafe. And then we also have the inattentive presentation, which is a little bit harder to identify because these are more internal symptoms. So they're not disruptive like in class or anything, but they do have difficulty with organizing things and staying on topic and staying on tasks and all that kind of stuff. And then we've got the combined presentation. So this is symptoms from both categories. All right, you can go on to the next one. Okay, so in the past, people have misunderstood it as a childhood disorder, when in reality, the symptoms persist into adulthood in 40 to 60% of cases. Like I said before, the hyperactive symptoms are way more obvious in childhood, but the hyperactive and impulsive symptoms often decline with age, while the inattentive symptoms will persist with age. All right, go ahead to the next one. Let me do the next slide. There we go. All right, perfect, thank you. So in childhood, we have a lot of supports for managing these symptoms. So we have more structured environments, we have accommodations, we have support from our adults, to manage time and complete tasks, as well as financial support. But in adulthood, the task demands increase, and we're expected to start handling all of these responsibilities without any supports. But ADHD makes that really hard for a lot of people. And by adulthood, the treatments just aren't really available, which is, why I want to highlight OT as a possible service that could be added. All right, go ahead to the next one. because the ICD-10 codes that I'm including here are more executive functioning based, I've kind of added a little bit of background information on that. It is an umbrella term for a lot of different skills, basically things that are targeted towards a goal-oriented task. So I'm not going to go through all of these, in much detail just for the sake of time, but I did want to add them here so that you guys can see what those are. And I want to talk about the ways that executive functioning impacts daily life because it is really impactful. All right, you can go to the next one. All right, so some of the most common areas of difficulty based on the research are self-care and home management. So this would be things like personal hygiene, cooking, and cleaning. Employment can be difficult. Fulfilling work responsibilities are difficult, such as meeting deadlines, attending meetings, and staying on task during the workday. Health management is difficult, such as things like managing doctor's appointments and remembering to take medications, as well as, in my case, what I've found is following through with a treatment plan. So I can offer suggestions, but then if someone has, limited executive functioning skills and can't follow through with that, then it becomes really challenging for me to address other symptoms. There are other basic activities that are difficult, but these are the most common ones, as well as social relationships can be really hard, but also really impact quality of life. And for a lot of people, this can result in low self-esteem and also comorbid diagnoses like depression, anxiety, and substance use disorder. All right, next one. Okay, so there's no one-size-fits-all protocol for this. This is because everyone has different symptoms. Everyone experiences life differently. But for that reason, therapy should be highly individualized and is often more effective if it's multimodal. So most people know the benefits of pharmacological treatment. These are the most widely researched and accepted treatments. But then we also have other areas that we can treat, like cognitive training, physical activity, environmental modifications, task modifications, compensatory strategies, sensory processing, and coordination. I've included those too because this is really common in people with ADHD, and it should be assessed and treated if necessary. All right, go on to the next one. All right, so what is OT? A lot of people misunderstand OT, think that, we are vocational rehab when we're not. Our service is inherently multimodal and individualized. The goal of what we do is to improve a person's ability to complete their everyday tasks. We call those occupations. We use a model called the PEO model to improve people's performance skills, create an environment that meets their needs, and change the way that people complete a task to make it more achievable. We address all of these simultaneously so that our patients can improve their performance as quickly and as easily as possible. All right, go on to the next one. Sweet. Okay. So I'm just going to go through a few different examples, some specific examples of how we can treat each area. Perfect. All right. So for the person, we'll address performance skills. So this can be, again, cognitive skills training, emotional regulation strategies, stress management, physical activity, sleep hygiene, and structured habits and routines. Okay, go on to the next one. We'll look at the environment and we'll adjust that as needed to improve performance. This includes reducing distractions, organizing the environment strategically. This is going to look different for each person. That's why it's highly individualized. We look at adding or reducing sensory stimuli as needed, creating opportunities for movement during functional tasks, and creating dedicated spaces for specific tasks. All right, on to the next one. All right, finally, we look at the way that someone is performing their activity. People might benefit from external supports, such as visual and auditory timers. This will improve time management, task simplification, visual sequencing aids, compensatory strategies, and organization of the materials needed for a specific task. All right. Go ahead to the next one. Awesome. So to further, make this make sense for people who aren't OTs, I've added some specific examples of treatments that we use for different tasks. So some specific interventions that we'll use to improve home management would be things like practicing a consistent routine. This makes the task more automatic and requires less planning for someone with executive functioning deficits. We can also use a step-by-step visual sequencing aid. This can help them initiate a task and also pick up where they left off if they do get distracted, which is fairly inevitable. We can use like an organized bin of supplies. So this will reduce the mental energy that people need to gather the supplies before beginning a task. For some people, just the act of remembering gathering those materials can be really mentally exhausting and will prevent people from initiating the task itself. And then for some people, the addition of auditory stimulus like music or an audiobook or something like that can actually reduce the likelihood of getting distracted by other things in the environment. Go on to the next one. Awesome. All right. For some people, to improve work performance, they'll benefit from noise canceling headphones. This just reduces the auditory distractions and makes it easier to focus on tasks. Standing desk and alternative seating allow for movement during a task and reduce restlessness. A large print calendar can help bring awareness of the different things that are expected of them in the workplace. Things like deadlines are really important. I've also found that it's helpful for some people to write the deadline like a week before it's actually due to reduce the procrastination. They can also use daily checklists. This can help people stay focused throughout the day, get back on track if they do get distracted. And actually, the act of checking off completed tasks can help activate the area of the brain associated with instant gratification. And this fuels motivation and keeps people fulfilling their daily tasks. All right, go ahead to the next one. All right, this is a huge one that I work with people on. We might use planners to keep track of appointments, and they may benefit from an alarm to actually check the planner, as well as an app that will send multiple reminders for upcoming appointments. There are different medication organizers that are super helpful. Some of them actually have alarms that are built in so that people have to physically go to the organizer to turn off the alarm, which makes them more likely to actually take the medication. And then I will recommend a visual aid and habit stacking for different routines. Habit stacking is a strategy where you pair a new habit with a previously existing habit to make it easier to remember to do it and become more routine. All right, go ahead to the next one. All right, so here's a little summary of what I just talked about. Executive functioning has a huge impact on daily function. OT is unique because we can focus on the specific tasks rather than just skill training to improve independence. And in my practice, I've found that pretty much any person with executive functioning challenges benefits from OT because we are so highly individualized and multimodal. We can provide a lot of different services within one treatment plan. All right. Perfect. Okay, so what I want to specifically propose is the inclusion of the two ICD-10 codes that I think are most applicable here, which is R41.80, attention and concentration deficits, as well as R41.844, frontal lobe and executive functioning deficits, underline ADHD. So when OTs, PTs, speech therapists, when we treat people, we're not coding the diagnosis, we're coding the symptoms that someone is experiencing. And as of right now, those two ICD-10 codes do not exist in the prioritized list of services, even though a lot of people experience these symptoms. Also, the codes that we use are under guideline note 6, which is rehabilitation and habilitative therapies. And I would love for that to be included, for ADHD to be included under that guideline. All right, go on to the next one. Okay, so I have included some ICD-10 codes that are covered currently just to illustrate that this is something that OTs treat. But unfortunately, the codes that exist are very specific to a population. So this is in childhood or in older adults who are having cognitive decline, or people who've had a specific health event that has caused the deficit, such as a stroke or a traumatic brain injury. So this is very limiting because, you know, there is a whole broad spectrum of people in between childhood and older adults that could benefit from these services as well. And then I think this next one might be the last one, other than references. So I wanted to add this because, you know, if we talk about this and we move forward with this, there's a lot of opportunity to add these codes to other areas. So this is really common also in autism. And then this is common in people that don't have a specific diagnosis of ADHD. People have executive functioning deficits for a multitude of reasons, a multitude of diagnoses. And so I just wanted to kind of highlight that this is something that could be discussed further in other areas as well. My next couple slides are going to be references. And I know that was a lot of information in a really short time. It's also very, very surface level. So I would love to be able to share more about this in the future. And I would also love to discuss this further with you guys now if we have time.
Thank you, Mrs. Gaffney. Yeah, we have just a little bit of time.
About 8 minutes.
Oh, about 8 minutes.
Oh,
Yeah. So, thank you. You've done a lot of my work for me by finding all of the
Yes.
codes and the
Yes.
lines.
That was my hope. That was my hope. I want to make this as easy for everyone as possible.
Yeah, and I haven't had a chance to look through any of your references. So I will take that slide. Do we have a copy of that? Did you send us a copy? Okay, thanks. So I will look through all of that material that
I also have the PDFs already compiled. If you want me to send those to you, all the research
that would be
articles are
great too.
compiled.
Yeah.
Yeah, absolutely.
It's just the herc.info, which is
Okay.
it's one of the things in the chat. That's the best
Okay.
place to send it to. And so what normally happens when we're asked to look at something is I'll look at the literature you send, see if there's any other literature I can find, maybe reach back out to you to get more information. And then we typically put this type of thing on an agenda. As I mentioned with our first presenter, we have very full agendas in the next couple meetings, but probably sometime in the summer or fall, this will come to a commission meeting for consideration. And what we normally do is once we have picked a meeting that we're going to put it on the agenda for, I can let you know. We put all of our materials out for public comment 6 weeks before the meeting, and you're welcome to look at what the staff proposal is and comment on anything, whether you support it, whether you'd want changes, whether you think you hate it, you know, whatever your comments are. And then we take that into account and then come up with final meeting materials a week before the meeting. And then at the meeting, if you want to actually talk to the commission, you are welcome to do that. And we can work with you behind the scenes on kind of setting up what would work best for you.
Awesome.
And like I said, I can't promise a meeting. I'm thinking maybe August or the fall. But yeah, if you want to send the PDFs, I'll take a look through the things that you have. And thank you for doing a lot of my background work for me.
Oh yeah, absolutely. It's something that I've been looking into for a really long time because this comes up so often in my practice.
Are you seeing like private insurance like Blue Cross or, you know, Providence or anybody? Is any other payer paying you for this?
Not for this. So our facility, I work at G Street Integrated Health. It's in Springfield, Oregon. We as a facility almost exclusively treat OHP. So I may have a couple of people who have transitioned to Medicare, who were already patients of ours. I also, on an unrelated topic, I do wheelchair evaluations with New Motion. So I do see private insurances for that, but I don't address this kind of stuff there. But yeah, the reason I've become really interested in it is because a lot of my people struggle with this. And I'll have people who I see for things like chronic pain. And later in the treatment, it comes up that, you know, they can't follow through with an exercise program to help with the chronic pain, or maybe some of these executive functioning deficits are causing more trouble with those activities than even the chronic pain does. So that's why I really, really became interested in it and found it surprising that it wasn't something that was already covered.
Great. Yeah.
Can you break that down a little bit more? How does it relate to chronic pain?
So it's not specifically related to chronic pain. So what will happen is I will receive a referral for chronic pain. So if someone's having shoulder pain, it's limiting their ability to, reach up in the cabinet, or it's just limiting their ability to do all sorts of different things. What will typically happen is I'll give them an exercise program, or I'll give them some suggestions, and come back the next session. They're like, oh, I just can't figure out a way to work that exercise program into my routine. We start breaking that down. Why is this happening? Turns out it's happening more so because of the executive functioning deficits that are related to the ADHD diagnosis. The ADHD is often comorbid with whatever, and it's not just chronic pain, it can be anything.
Mhm.
But what I'm finding is a lot of my people with comorbid ADHD are just having a really hard time following through with treatment plans. And then we're also finding out, like, okay, that's actually what's contributing to you having difficulty in other areas as well beyond the chronic pain.
Yeah. Okay. Thank you. That's helpful.
Yeah.
Okay.
Great. Do you have any more questions or? Are we-
No, I will probably be in touch.
Yeah.
And yeah, if you could just email me the PDFs, that would be really great.
Absolutely.
Right.
And then I will we'll work behind the scenes, kind of come up with a proposal, and we'll reach out to you and kind of keep you in the loop of what's going on.
Sounds
Great.
great. I appreciate
Awesome.
you for coming, Betsy, and thank
I
you
really
so
appreciate
much.
y'all for listening to this. This is something that's super new. And it's very different. And so I recognize that, and that takes some extra time, but I appreciate y'all listening to this because it is super important to me.
Great. Thank you.
Absolutely. Appreciate you so
Nice.
much.
Yeah, thank you.
The next segment will be a kind of a discussion with some Q&A. So get ready with our medical director about a couple of topics that we're looking at for the benefit update project. So take it away, Ariel.
Yeah, thanks, Daphne. So just for those of you who weren't able to join us at our last listening session or haven't been to a lot of our recent meetings, the HERC is involved in what we call the Benefit Updates Project. So up until 2027, so starting in the 1990s, the Oregon Health Plan has had coverage, a lot of the coverage policy determined by what we refer to as the prioritized list of health services. So some things would be called funded and some would be non-funded. We, in 2027, will no longer have that waiver from our federal partners, and we will need to look at coverage for all diagnoses, regardless of whether they're currently in the funded or non-funded. And we're doing a pretty extensive review of all of our non-covered diagnoses to see what procedures, treatments, other things they might need. And we're bringing this to the commission kind of in chunks, sort of roughly based around sort of what specialty might see that. And we are having a lot of really good in-depth discussions, and the HERC has been making proposals. So these are things the HERC has decided on. They're not 100% final, unlike most HERC decisions, because we're still kind of determining some pieces of the new policy. So these are sort of approved in general concept, 99% approved. Some details may change as OHA moves forward with sort of the global look at this. But in the last couple of HERC meetings, we've talked about some diagnoses and services, and had HERC staff have reached out to various specialty groups. One of the big things that we had been hearing from our sports medicine orthopedic colleagues was that a lot of the conditions that they refer patients to for physical therapy aren't covered for physical therapy. So we were looking through these, and the HERC agreed that we should add coverage. So one of the decisions that we made at our March meeting was to add physical therapy coverage for sprains and strains that are more minor. That sometimes sprains and strains might be referred to by degree, especially shoulder sprains and strains have various degrees. Others may have kind of decide how severe they are based on sort of functional impact. And there's the medical framework would be sort of more severe, moderate, or mild. So there's coverage added for more mild sprains and strains, realizing that even if something is expected to just self-resolve, in some people there may be more of an impact. They may not be able to, there may be various reasons that they need physical therapy. So that coverage was added, and that will start in 2027. And then the second area that we talked about in March, we have worked with some eye specialists, ophthalmologists, looking at a lot of conditions that are currently non-funded, because the commission has felt that these are things that are generally something that does not require more than an office visit and maybe some very inexpensive, like antibiotic eye drops or something, that don't require any management on the part of the health plan. So we don't have to approve a PA for an expensive medication or a PA for a surgical procedure. So we have looked at a bunch of those diagnoses, and the HERC agreed with the ophthalmologist that we should add some coverage. So these are conditions that are in the cornea, which is that clear layer at the front of the eye, and things where the eyebrow is sort of falling into the line of vision, and then just a whole variety of again, these kinds of conditions that are probably not very significant to eye health, but which might require multiple visits with an ophthalmologist to see how something is actually improving. So all of that was just approved. That again will take effect in 2027. So I wanted to highlight those two areas. So as part of this benefit updates project, we are not removing any services. We're really looking to see where we need to add services. So these were two areas where I think quite a few services were added. A lot of the other areas that we looked at, we determined we really only need sort of that office visit, advice from your healthcare provider, and perhaps inexpensive medications that there's no prior authorization or other kind of controls over. And so I would hopefully that if any of you had concerns about physical therapy or ophthalmology, that gives you a little background information. If you have other areas where, as our speakers were pointing out, we aren't covering certain services, this is a great time to bring those to our attention, the HERC.info. That can help HERC staff be aware that maybe we do need to even take a deeper look at something. And we invite you also to come and either virtually or in person and listen in on any of the HERC conversations about these BUP proposals. And then we have some time now. If anyone has questions, wants to ask staff anything about our rationale, bring up other things that you would like staff to consider, or anything else you'd like to hear about with the benefit updates. Just of note, at our last listening session, Jason Gingrich, our director, gave a presentation that should be available online if you want to go and just look further and get some information about the whole project. You're welcome to raise your hand. We're happy. Oh, Daphne, you're on mute.
Story of my life. You're welcome to put a question in chat or just to raise your hand, and we'll go from there.
You're also welcome to look at our website. We have a lot of materials, and there's a searchable area that you can look at the BUP topics. We are happy to have you submit written comments. We're also happy to have people sign up to give spoken verbal comments at any of our meetings.
I'm not seeing any hands raised or questions in the Q&A. Let's give it another couple minutes. If not, we can give people some time back.
And again, if you, after the meeting, something strikes you that, oh, I needed to, I wish I'd brought this up, herc.info, it's in the chat, is a great way to reach us. And even if it's not something that we can help you with, we can help refer you or to somebody who could answer your question or concern.
All right. Well, it looks like we can give people some time back. Thanks for the thoughtful and thought-provoking discussion today. Your public comments are always welcome at the Value-Based Benefits Subcommittee and the Health Evidence Review Commission. And I'm going to post that link into chat. There you go. We would be grateful to you for taking a survey about today's event. And again, posting that in the chat. I'm going to stay on for a couple minutes in case people want to ask me any questions about that. Also, our next listening session is on the 30th of April, and you can register for that on this page. Great. Thanks, everyone. Thanks for coming. Appreciate you.
Should I stop the recording?
Yes, please.